I am Dr. Saqib Mansoor from my channel Learning Anatomy, and this is the last lecture on the basal ganglia anatomy, which is the clinical anatomy of the basal ganglia, the basal nuclei. So this is to say this is a very important discussion of all the various diseases of the basal ganglia. The most important, you can see the picture, is the Parkinson disease. So disorders of the basal nuclei or the basal ganglia are two general types. Number one, they are hyperkinetic disorders. Number two, they are hypokinetic disorders. Hyperkinetic disorders are those in which there are excessive and abnormal movements, for example, chorea, athetosis, and ballism, right? Chorea, athetosis, and ballism are the hyperkinetic disorders where movement is excessive and abnormal. Hypokinetic disorders are those where there is a slowness or lack of movement, akinesia or bradykinesia, right? So what about the Parkinson disease? It has both types of the motor disturbances. At the same time, it has some hyperkinetic disorders and also some hypokinetic disorders. I will elaborate in the next coming section of the discussion. So this is a grouping summed up by me. Disorders of the basal nuclei or basal ganglia. Hyperkinetic disorders are chorea, athetosis, or ballism. Hypokinetic disorders, Parkinson disease, includes both types of motor disturbances. So first of all, I take up the chorea. Here the patient shows involuntary, quick, jerky, irregular movements which are non-repetitive. Examples are swift grimaces and sudden movements of limbs or head are very good examples. And next is the athetosis. Athetosis comprises of slow, sinuous, writhing movements that commonly affect the distal segments of the extremities, upper limb and the lower limb. Globus pallidus degeneration takes place with the breakdown of circuitry involving basal nuclei and cerebral cortex. This circuitry is discussed in detail in my previous lectures. Then is the Huntington disease. It is an autosomal dominant disease of inheritance where the onset occurs mostly in adult life. Death generally occurs 15 to 20 years after the onset. The disease is traced to a single gene defect on the chromosome 4. It's a chromosome 4 number where the defect lies. The gene on chromosome 4 encodes a protein called as Huntington, whose function is not determined. The codon CAG that encodes glutamine gets repeated many more times than normal, right? Men and women are affected with equal frequency. Unfortunately, mostly manifests itself only after they have had children. Following characteristic signs and symptoms are present in Huntington disease. That's a Huntington disease, signs and symptoms. First of all is a choreoform movements. They first develop as involuntary movements of the limbs and facial grimacing, twitching of the face. Later, more muscle groups get involved and the patient becomes immobile and is unable to speak or swallow. Number two, quality characteristic of the Huntington disease is the progressive dementia. It develops with loss of memory and intellectual capacity. Both are lost, loss of memory and loss of intellectual capacity. In Huntington disease, there occurs degeneration of the GABA secreting, acetylcholine secreting, and substance P secreting neurons on the striatonigral limiting pathway. This results in overactivity of the DOPA secreting neurons of the substantia nigra. In this way, the nigrostriatal pathway inhibits caudate nucleus and the putamen. This inhibition results in abnormal movements observed in this disease. This whole circuit is discussed in detail with diagrams in my previous two lectures. Computed tomography scans depict enlarged lateral ventricles due to regeneration of the cardiac nuclei. Of course, they're in close relation to the lateral ventricle. Medical treatment of Huntington chorea is disappointing so far, unfortunately. Then is the Sydenham chorea, the St. Vitus dance. It is a childhood disease where there are rapid, irregular, involuntary movements of the extremities, trunk, and face. It is associated with rheumatic fever. St. Vitus dance is associated with rheumatic fever. And the antigens of streptococcal bacteria have a structure similar to the protein present in the membranes of the striatal neurons. The host antibodies combine with the bacterial antigens as well as they attack the membranes of the neurons of the basal ganglia. This produces the choreiform movements, which are fortunately transient and they occur full recovery. So this is very fortunate about the St. Vitus dance that full recovery occurs afterwards when the streptococcal bacteria attack. Then is the hemiballismus. Hemiballismus is a form of involuntary movement that is limited to one side of the body, hemiballismus. Here, proximal extremity musculature is mostly involved and the limb suddenly flies out of control in all directions, right? A sort of the dancing movement. The lesion, which is commonly a small stroke, is located in the opposite subthalamic nucleus or its connections. I told you this subthalamic nucleus involved in the indirect pathway of the basal nucleus, basal nuclei in the previous lecture. Smooth movements of different parts of the body are integrated in the subthalamic nucleus. Then is the hepatolenticular degeneration or the Wilson disease. Wilson disease, it is an autosomal recessive disorder due to a defect in metabolism of copper, which is in fact ceruloplasmin. Its gene locus is on chromosome 13, right? So the chromosome 13 is the culprit here in the hepatolenticular degeneration of the Wilson disease. It results in clinical manifestations of tremor, rigidity, and athetotic choreiform or athetotic movements. The commonest neurological sign is tremor. It produces psychiatric symptoms that include psychosis, dementia, and personality disorders. So what psychiatric symptom? Psychosis, dementia, and personality disorders. It's a very characteristic feature in that which helps to diagnose it. That is a pathognomonic of that disease, right? Which is the corneal Kaiser-Fleischer ring. Kaiser-Fleischer ring, right? This is present in the, Wilson disease or the hepatolenticular degeneration. It is pathognomonic. It is marked by lesion in liver. Also, cirrhosis known as that. So the word hepato suggests hepatolenticular. It's a cirrhosis of the liver, and in the lentiform nuclei, necrosis and cavitation of the putamen, hepatolenticular. This is the liver, and this is the lenticular, the lentiform nucleus, right? Diagnosis is by decreased serum ceruloplasmin. So there would be decreased serum ceruloplasmin level and elevated copper concentration in liver biopsy and increased urinary excretion of copper. The three parameters for diagnosis of the Wilson disease, right? Decreased serum ceruloplasmin, elevated copper concentration in the liver biopsy, and when urine is examined, there is increased excretion of copper. So what is the treatment of the Wilson disease? It is with copper chelating agent, D-penicillamine and pyridoxine for anemia, right? So two drugs are involved. D-penicillamine, which is a copper chelating agent, it chelates the copper, and also the pyridoxine, which is given for treating the anemia. Then is the Tourette syndrome. So Tourette syndrome. The primary features of this disorders are motor and vocal tics. Characteristic of motor tics. What are the motor tics? Include brief, sudden involuntary movements of different parts of the body. For example, shrugging of the shoulder, turning in a circle, and eye blinking, right? So this is all uncontrolled movements, which is the Tourette syndrome. What are the vocal tics? These were the motor tics. And then what are the vocal tics? It may involve sounds that are irritating in pitch, compulsive expression of obscenities. So this is a term used for a compulsive expression of obscenities. It is known as coprolalia, right? Coprolalia. You can see this word is derived from copro, which is related with feces. So obscenities would be uttered by the patient uncontrollably. Repetition of words is palilalia. Repetition of words are done by palilalia, and repeating words of others. As the others are speaking, this person also speaks along with that. It's very strange to have these all symptoms. It's very embarrassing socially and debilitating disease, this Tourette syndrome, like in this way. In many patients, the disorder subsides in early childhood, fortunately. In others, the disorders may subside but reappear again at a later period and persist throughout life. So this is very unfortunate if it persists throughout, but mostly it clears and subsides in the early life, early adulthood. So Tourette syndrome continues. Evidence supports the possibility of a genetic basis for this disorder, but knowledge of causal factors remain unknown, right? The cause is still unknown, though a genetic basis is suggested. So treatment, haloperidol, which blocks dopamine D2 receptors, has been shown to be an effective treatment for Tourette syndrome, whereas symptoms worsen following L-DOPA administration, right? So though two drugs are to be discussed, first of all is the haloperidol. It blocks the dopamine D2 receptors, right? It is very effective treatment for Tourette syndrome. Whereas if L-DOPA is administered, like in Parkinson's disease, it worsens the symptoms of the Tourette syndrome. Then noradrenergic alpha-2 receptor agonists, for example, clonidine and guanfacine. Clonidine and guanfacine have also been used for treatment of this disorder, right? Two other drugs which are non-adrenergic alpha-2 receptor agonists, that is clonidine and guanfacine, they are also employed for treating this disorder. It has been suggested that Tourette syndrome is associated with dysfunction of the caudate nucleus and its linkage with the prefrontal cortex, although anatomical and clinical evidences in support of this view remains incomplete, right? So there are suggestions of involvement of the dysfunction of the caudate nucleus and its linkage with the prefrontal cortex, right? But it's not proven. So tardive dyskinesia, a few words more about that. It's a syndrome of repetitive choreiform movements which affect limbs, trunk, and face. This is another version summed up by me. It results from treatment with antipsychotic drugs, for example, butyrophenones, phenothiazines, or metoclopramide, right? It can be a result of these three drugs as well. Iatrogenic tardive dyskinesia, TD. So another brief discussion of another disease or LS associated with the basal ganglia. This is the restless leg syndrome. Very common. This state that causes an uncontrollable urge to move legs, right? What is restless legs syndrome? This is an uncontrollable urge to move legs, usually due to an uncomfortable sensation, right? Typically occurs in the evening or at night time hours when patient is sitting or lying down. And the patient sits for a longer period of time or lies down for a longer period of time. So it is likely to have, if he is sick, restless legs syndrome. Unpleasant feeling is temporary, eased by moving. As he or she moves, the feeling is temporarily eased. Evidence suggests that RLS, restless leg syndrome, is related to problem with the basal ganglia. I've already told you. Of course, we are studying all the clinicals of the basal ganglia, and this is related to the basal ganglia anomaly. So the most important, what I believe is very common in all over the world, especially the United States of America, right? And it is a progressive disease where cause is unknown. Some patterns are iatrogenic or post-encephalitic, etc. I will discuss in the end as well of the Parkinson disease, but mostly its cause is unknown. It starts between the ages of 45 and 55 years typically. It is associated with neuronal degeneration in substantia nigra and to a lesser extent in globus pallidus, putamen, and the caudate nucleus, right? So you note it out, right? The substantia nigra defect. Substantia nigra is a structure situated in the midbrain. I told you and discussed with you in the previous lectures, and also one of my lecture on midbrain anatomy. So about 1 million people in the United States have Parkinson disease. I told you already. It's quite common in the United States of America. 1 million people, quite a big number, large number. The degeneration of the neurons of substantia nigra that send their axons to corpus striatum causes a reduction in the release of the neurotransmitter dopamine, right? So this is a neurotransmitter involved, right? So this is it's decreased, right, within the corpus striatum. This produces hypersensitivity of dopamine receptors in the postsynaptic neurons in striatum. This is very important, this portion, and I discuss it again, that there occurs degeneration of the neurons of the substantia nigra that send their axons to the corpus striatum. So it causes a reduction in the release of neurotransmitter dopamine within the corpus striatum. So in a nutshell, dopamine within the corpus striatum is decreased. So what occurs as a result of this decrease in dopamine within the corpus striatum? There is the hypersensitivity of the dopamine receptors in the postsynaptic neurons in the striatum. You know, the corpus striatum is the caudate and the putamen. The following characteristic signs and symptoms are seen. I'm giving you a detailed account of the Parkinson disease. First of all, is typical tremor, also known as the pill rolling tremor of the Parkinson disease, and we have to compare this tremor with the tremor, intention tremor seen in the cerebellum disease, the cerebellar disease. So tremor is produced as a result of the alternating contraction of agonists and antagonists, right? So simultaneously an agonist is contracting, and at the same time antagonists are also contracting of a particular place. The tremor is slow and is seen most obviously when the extremities are at rest. So resting tremor, the tremor disappears during sleep. It is to be distinguished from the intention tremor present in cerebellar disease, which only is present when purposeful active movement is performed, right? So the cerebellum tremor is the intention tremor, right? And the pill rolling tremor present at rest in the Parkinson disease. This is the, pill rolling tremor, right? This is the thing. This is the position of the patient with the typical position of the Parkinsonism patient. I will discuss in the end when all the things or clinical characteristics are discussed. The second is the rigidity, right? So first was the, I will give you a word trap, T-R-A-P, so the tremor, and then rigidity, T-R. Our second word of the key trap is the rigidity. It is different from the rigidity caused by upper motor neurons rigidity in that it exists to an equal extent in the opposing muscle groups. So there are two types of rigidity. Plastic rigidity. When the tremor is absent, the rigidity is felt as a resistance to passive movement and is referred to as the plastic rigidity. It is uniform and constant throughout the entire range of motion, right? The plastic rigidity. Whereas the cogwheel rigidity, when the tremor is present, muscle resistance is overcome as a series of jerks known as cogwheel rigidity, right? So two types of rigidity is present in Parkinson's disease, plastic and cogwheel rigidity. So trap continues TR con and the app A. Then third word is akinesia or bradykinesia. Trap TRA. This is akinesia or bradykinesia. That is a difficulty in initiating and performing new movements. And here the movements are slow. Voice is slurred and unmodulated. Unmodulated means tuning the pitch or tone of the voice is lost. That would be very monotonous voice, right? No effector tone is related with that, right? The effector tone like I'm using, sometimes my pitch is more and sometimes high, bringing up and down and giving emphasis on some words. The Parkinson's the patient cannot do that. Swinging of the arms in walking is lost, and the face is expressionless, that is masked faces, right? So as we go on with the Parkinson disease, it has the trap. Last word is the trap, TRAP. This is trap is for postural disturbances. The patient stands with a stoop with arms flexed, right? This is the characteristic stoop with the arms flexed. He or she walks with short steps and often is unable to stop. He or she may break into a shuffling run to maintain the balance. This is known as the Parkinson's gait or fascinating gait, right? So that's very, very difficult. He has the tendency to fall and feels like he's trapped in his own body. So in the last, it's no loss of muscle power and no loss of sensibility is present. So since the pyramidal tracts are intact, the superficial abdominal reflexes are normal and there is no Babinski's reflex. Deep tendon reflexes are also normal. So let's have a look at the picture now, right now, right? Masked facial expression, told you already, no expression of the face, the muscle of the facial expression are not working, right? So the facial expressions are lost, flat, mask-like faces. Then the posture is stooped, there is stooping of the posture and there is present rigidity and the flexed elbows and wrist. Elbows are flexed here and the wrists are also flexed here, you can see. And then is the trembling of extremities, the tremors, right? They are tremors. These, you could see these in shaded areas. They are the tremors at the both extremities, lower limb, feet, and the hands in the upper limb. Then the shuffling short-stepped gait. Right? This is due to the name given to that is the fascinant gait. This is slightly flexed hips and knees, right? They are slightly flexed. There's a slightly flexed, and the upper extremities are more flexed here and here. And a forward tilt to the trunk. This posture of the Parkinson, there's a forward tilt towards the forward in the anterior direction. This is forward tilt of the trunk. So I told you already, for some type of Parkinson disease, the cause is known. Mostly it is not known, Parkinson disease cause, but here I have given you three types where the cause is known. Number one is a post-encephalitic Parkinsonism. It occurred following the viral encephalitis outbreak of 1916 to 1917, where damage occurred to the basal nuclei. Iatrogenic Parkinsonism develops as a side effect of the antipsychotic drugs, phenothiazines, for example, meperidine analogs. These are consumed by drug addicts, and carbon monoxide and manganese poisoning can also cause symptoms of Parkinsonism. Atherosclerotic Parkinsonism develops in elderly patients with hypertension, right? So three causes. Number one, post-encephalitic Parkinsonism, iatrogenic Parkinsonism, and atherosclerotic Parkinsonism in the hypotensives, atherosclerotic. So here we go with the treatment of Parkinson disease. It can be treated by giving medicinal treatment, or by surgical treatment. So first of all, we'll discuss the medicinal treatment. So the target is to raise the dopamine level, right? So first drug used is the L-Dopa. Why L-Dopa, not the dopamine directly? Because dopamine in itself cannot cross a blood-brain barrier, whereas its immediate precursor L-Dopa can cross blood-brain barrier. So it is used, and with the dopaminergic neurons in the basal ganglia take up this L-Dopa and convert it to dopamine. So this does the rest of the job to cure the relieve the Parkinson disease. A second drug is selagelene. What does this selagelene do? It inhibits monoamine oxidase, right? Which destroys dopamine, is useful in the treatment of the disease, obviously. So selagelene inhibits monoamine oxidase, which acts to destroy dopamine. So as this dopamine destruction is reduced, so indirectly the level of the dopamine is increased, right? So there is also evidence that selagelene slows down the process of degeneration of the dopamine secreting neurons in substantia nigra. So it's also targets the substantia nigra of the midbrain. So then a very interesting treatment, human embryonic dopamine producing neurons transplantation into the caudate nucleus in the putamen. It improves motor function in Parkinson disease. So now the surgical treatment could be interesting, pallidotomy and thalamotomy. As most symptoms of the Parkinson disease are produced by an enhanced inhibitory output from the basal nuclei to the thalamus and precentral motor cortex. So pallidotomy. What is pallidotomy? Surgical lesions in the globus pallidus is effective in relieving Parkinsonian signs, right? So pallidotomy is the removal of the globus pallidus, right? We have to give the surgical lesion, the globus pallidus are removed by pallidotomy. Such procedures are carried out for patients who are not responding to medical treatment. I already told you. Another surgical procedure, the second one, is thalamotomy, right? It's a surgical procedure where surgical destruction of a small part of the thalamus is done. In fact, it's a ventral thalamotomy. Thalamotomy is used to treat intractable tremors. Pallidotomy is used for medicinal resistance, rigidity, right? So let's move to the summary of the Parkinson disease, the last slide of the today's lecture. So I know this is patient lectures, listening to that. We'll do this video, watching and listening, because it's a lot of difficult new terminology for some of the neuroanatomists and anatomists. So I've tried my best to make it the presentation very simple and precise. All the important clinicals of the this basal ganglia are discussed. Parkinson disease is associated with neuronal degeneration in the substantia nigra and to a lesser extent in the globus pallidus, putamen, and caudate nucleus. This is a summary of the Parkinson disease. Very important clinically, very much. 1 million people in the United States of America already do have it. TRAP is a memory tip for that. The mnemonic, you can say, number one is the TRAP, tremor, which is tremor is defined as the alternating contraction of the agonist and antagonist of a joint. Then TRAP R, this rigidity, which rigidity, this is the cogwheel rigidity typically, and also the plastic rigidity. So cogwheel rigidity is that where when the arm is moved, for example, their movement is resisted occurs in motions and steps. And with the number A is TRAP akinesia, bradykinesia. Movements are very less. And TRAP P is postural disturbances, right? This is a typical stupor of the patient. So types are I told you already, post-encephalitic, iatrogenic, and atherosclerotic Parkinsonism. So the some of the treatment, medicinal L-Dopa mainly, and also the selagelene. And the surgical treatments to pallidotomy, the removal of the globus pallidus, for it is used for rigidity. If the rigidity doesn't relieve by medicine, so pallidotomy is performed. And if the tremor is not being cured by the medicine, it is intractable, then thalamotomy, a small portion of the thalamus is removed, right? So thalamotomy basically is a ventral thalamotomy. So thank you very much for again for listening to my lengthy video, relatively, but the topic is very important. All the diseases discussed with you. Please support my channel, subscribe it, and like and share. Do comment, bro. Thank you very much. Goodbye.